Welcome everyone to the Hive P2 research panel discussion. My name is Narissa Ramsey, Hope for Hive P2 mom, and I am joined with Dr. Wendy Chung, Director of Clinical Research at Safari, Tally Foster, OT, and Dr. Siddharth Srivastava. Thank you all so much for your interesting presentations. For everyone listening in, you should be able to see and hear me on your screen, although I won't be able to see or hear you. We welcome everyone to ask questions in the Q&A box. Please remember to avoid including personal health information in your questions for your own privacy. We apologize in advance if we do not get to your questions, but we will try to cover as many as possible. With all that said, let's get started in the Q&A discussion and hear from you all. So Tally, I found it so interesting that proprioceptive, vestibular, and tactile senses are the foundation of the central nervous system. And those three seem to be most dysregulated in my child. But my child has other sensory issues on top of these. For families with a child that has multiple and complex sensory regulation issues, which might feel overwhelming to tackle all at once, is there a priority area to start with, or is that really dependent on the child?
That's a great question. The answer is kind of yes to both. So if there are multiple sensory areas that are impacting regulation, it basically depends on of course, the individual situation. I think that the most important thing to remember is that you want to identify the priority areas that are most important to that child and family. So addressing those areas first will have the most impact, right? So that's always going to be your priority. What's affecting you the most? Think about what responses are causing any harm or perhaps the most disruptive. Those are the things you're going to want to likely tackle first. Then you want to consider why they're doing it or what they're needing, right? That being said, the point you made about the foundational systems, so the proprioceptive, the vestibular, the tactile systems, they are important always to consider as much as possible once you identify what works best for your child in those areas. Because as the foundation, we want to help them keep it as solid and as stable as possible, right? Because that's what everything's building off of. Which brings you to the kind of most important challenge, which is sticking with it. So once you identify those things and the strategies that help keep those areas regulated, you really want to figure out how to keep it going. It's not a one-time fix thing. And even though the goals, as I mentioned, include adjusting and changing thresholds, that happens over time, right? So it's not something that happens immediately. It takes a lot of persistence, and so we have to stick with it. If you notice a change in your child, you always want to go back and ask that question. What else has changed? What else have we stopped doing or started doing or doing differently, and go back to the foundation? So not an easy answer, but yes, stick with those foundational things as a basis. Always consider that they're super important, but you still need to prioritize the areas that stand out the most individually and then tackle them one at a time based on the child and the
That's
family.
great information. And I think that it's so hard to remember some of those foundational systems as well. When we think about sensory, we think about visual and hearing and tasting, and those foundations are so important. We have a question for Dr. Sid. I love that you pointed out that epilepsy affects each child differently. For many years, I had a specific idea in my head of what a seizure looked like, but then I learned about the variety of presentations. Some of the symptoms that you describe can overlap with sensory or behavioral responses, such as hand clapping, lip smacking, body jerking, heart racing, etc. Are there any ways to determine if some of these symptoms may be indicating a seizure instead of a behavioral reaction?
Yeah, that's a great question. Seizures can look like a lot of different things, and a common question in children who have autism or other developmental concerns is, how can I differentiate my child's behavior from a seizure? So a common scenario may come up is staring spells. So staring spells can be quite common in young children and children with any sort of developmental impairment. And in general, one way of differentiating between a behavior versus a seizure is trying to assess for responsiveness during the spell. So for example, if somebody is having a spell or behavior or whatnot, gently, saying their name or tapping along their hand or trying to stimulate them either verbally or through tactile means, to see if they respond to that bit of stimuli. In other words, do they temporarily stop the behavior? Do they say, oh, like, what are you doing? What's going on? Or do they continue doing that behavior? Sometimes you really need almost an obnoxious level of stimulation to kind of assess for responsiveness. So in some cases, if just saying your child's name or tap or kind of tugging at their hand doesn't kind of break them from the behavior, sometimes blowing in their face or tickling their nose may be that kind of almost obnoxious stimuli that may be necessary to differentiate, to see how are they truly not really responsive during the behavior, or are they? So a type of behavior in which you can elicit some sort of responsiveness to stimulation, be it calling their name, shaking their hand, blowing in their face, tickling in their nose, et cetera, et cetera. So if there's responsiveness, I think that makes a seizure less likely, versus if they continue that staring episode or other type of behavior despite these obnoxious stimuli, that may make it a little bit more concerning for a seizure. Sometimes, in general, sometimes it can be quite difficult to differentiate a seizure or not just by looking at something, or and ultimately a gold standard way of seeing if something is a seizure or not is having the spell while the EEG is running, because that can tell you, with good certainty whether that spell or that behavior is a seizure or not.
Excellent information. Thank you so much. We have another question. How do I keep my therapist motivated to keep working with my child as he keeps mastering and unlearning a skill, kind of back and forth? So Tally, you want to take
I
that
assume
one?
that's for me.
Yeah.
Okay. I think it goes back to making sure you're communicating your most current priorities, right? So that everybody's on the same page. I think therapists, just as families do, can get in ruts when we work with a child for a long time. And and that definitely, that 2 steps forward, 1 step back thing can be challenging. But I think making sure that if a therapist knows that a parent, that a family member still feels that's a priority area, it motivates you as a therapist to say, okay, I'm on the right track. I still want to go back to this. I still want to keep pushing for this progress in this area. It definitely gives you a different, from the therapist side, it gives us more reassurance that that is in fact what you want us to be working on. I think in general, we're pretty patient by nature, and we will work on things for a very long time. It's just more of a fear that, are we working on something that the parent isn't interested in anymore, right? Because sometimes those priorities change. So if there's a question of that, it can definitely muddy the water. So if you're at least communicating that what your priorities are, what you still think is important to work on, and what you kind of want to let go right now, that helps a lot to keep everybody kind of going forward on a path that makes sense. It also helps if you kind of are good at sharing the little things you notice that are different, because you see things in your home that may change, that may not show up in a clinic. So it also feeds back into that cycle of letting the therapist know, okay, these areas have made a difference, and it re-empowers that push to go forward, right? So it's just kind of human nature, but we all have that goes both ways, right? I think you're asking from the perspective of how we keep the therapist motivated, and I think the therapists often wonder how to keep the families motivated too. So it goes both ways, right? But I think the communication is a big important part of it, and priorities, right? So never be afraid to assess your, kind of look at what are your priorities, because they're not going to be the same all the time, and they're not going to be the same for each family member, and they're not going to be the same for each child. So you're the most important factor there, is the family, and knowing what the child and your priorities are for your quality of life.
Great. And I really appreciate, I feel like Tally and Sid, you both have touched on making sure to kind of reevaluate, and that things are dynamic, and you know, goals may change, medications, or you know, even the prevalence of having seizures, things change. So it's important to go back and reassess what's going on at a different point in time.
And Nerissa, if I may, could I also add on to that as well about motivation?
Yeah.
So sometimes when I'm talking to families, and this is kind of a general topic about motivation, and whether it's in the educational setting or providers or whatnot, so not necessarily specific to providers, but just, you know, generally speaking, sometimes, for example, if a family is really appreciating the effort, and an educator or a paraprofessional or somebody along those lines is making towards their child, you know, sometimes I'll say, well, you know, writing the school or the therapist or the school a note expressing appreciation, and then making sure their supervisors know how good a job they're doing. That way it gets communicated to the persons or the therapist or the educator or whatnot, you know, occupation or their work, what, you know, the effort that they're putting in. It you know, often their supervisor may say, hey, you're doing a really good job, like that's great. So it just creates a little bit of positive reinforcement to make the person really want to continue to put in all the effort that they've been doing. I think it's sometimes like these small gestures can go long ways.
Great point. We have another question for Dr. Sid. And I apologize if I'm saying this medication wrong. Depakote is causing a shake, shiver, tremor in my child. He's getting weak in the arms and legs, and every time we try to lower the dose and move on to Lamictal, he starts getting absence seizures. Do you have any recommendations on how to handle this situation?
Yeah, so I think there's a couple of things. So one of the common side effects of Depakote is a tremor. Sometimes the tremor can go away with reduced dosages of the medications, but sometimes it persists. In some cases, we've tried addition. You can try addition of certain vitamins to help with the tremor, and I'm happy to kind of talk about some of those details offline. But it can be hard to control the side effects. So if I guess is the question, I guess, what are ways to deal with the tremor while on Depakote, or are there alternative medications to pursue?
Yeah, I'm thinking maybe this is what alternatives are there to avoid that side effect.
Yeah, I think short of the addition of certain, you know, vitamins to help with the tremor, I think either dose reduction or trying a different agent is perhaps a possibility. Yeah, but I'm happy to talk more offline about that.
Great, thank you. Dr. Chung, we have a question for you. The graphs with the results from the Vineland assessments are really helpful to see. And I'm curious if it's possible to project development beyond 14 years of age. And does that rate of development slow or change at a certain point?
So I'm glad to hear this is a good way to see the data, to visualize or understand the data for the families. There are a lot of limitations to the data we have, though, and it's mostly just the numbers. the oldest person we have the Vineland data for is 14 years old. We do have a couple kiddos who are sort of the 9 or 10-year-old range, but we don't have anyone, for instance, who's 20 or 30 or 40 with the Vineland data. Not to say that they're not out there. We know they're out there. We know they're in the HiveP2 community, but it becomes hard to extrapolate or to be able to extend that line beyond 14 years until we have information directly on those people who are over 14 years. So I'm reluctant to be able to, make guesstimates about what goes on beyond there. It's better for us to just ask people who are, like I said, in their 20s, 30s, 40s, beyond that. I will say just, with that, I know those folks are out there. I know because they're part of the Facebook group. I'll also say that we know there are many more out there who aren't on the Facebook group. That is that most of the folks that are getting genetic testing to know they belong in this club are really young children. And that's just sort of who continues to access genetic testing, ask the question, look for answers. Not to say they're not out there. Like I said, I put this plug in because for any of you who are listening who have friends or family or mostly probably friends in your community of children, perhaps with special needs, and I want you to think in your communities now about adults with special needs, we set up this program called SPARK, S-P-A-R-K for autism.org. It's kind of our sister study, but it's for anyone who has an autism diagnosis. It enables them to get this genetic diagnosis to figure out if they belong in the HiveP2 community or some other club. So it's completely free. It gives back that genetic information. And if it's that helpful, that's one of the gaps I feel we really need to fill as a community about what happens through adulthood. And I do see there's another question that Narissa was probably going to come up to. And the question ultimately about, are there either life-threatening issues or life-limiting issues or other things that might come up, whether it's, I don't even know what to think about yet, but, any of those things, we really have very little information, and I think the adults are the answer for us. So if you've got other bright ideas about how to reach out to adults with special needs and make them aware of any options, we've done a lot of work on the legislative side and on the advocacy side to make sure that we now have recommendations. So these are professional guidelines saying that genetic testing like this should be available. We've done a lot in several states in terms of making sure with Medicaid plans that genetic testing is covered. So we're trying to move in all fronts possible to make sure that everyone can line up with the right club. But if you can think of other ways that we can work with the community, we're glad to pitch in.
Great. And then also just want to extend that question also to Dr. Sid or Tally. If, maybe we don't have the data on HiveP2, but what would we expect from a general development curve as you get into the teen and early adult years?
Yeah, I think it's a good question, and I think it's sometimes it's hard to predict. So I think one would expect kind of continued gains over time without regression. But I think we really need to study, have more data to say more definitively, what is the natural history of this disorder, and because every individual's profile is going to be unique, I think also we just have to be careful of not. So taking a look at the data you have, and also not necessarily, just being mindful of the fact that just because this is what the data shows doesn't mean that this is what will happen to your child specifically. So more data, the better, and just also being mindful that every individual is unique and may fall into a little bit of a different trajectory from what we know.
I'd love to chime in. I don't have enough, obviously I only have experience with one child with this condition, so I have no perspective on that beyond learning as we go. But as a kind of thought related to the therapy world, I think they're the variables that we have to consider when we're measuring progress and development and skills learned over time is just to remember how multiple interventions affect that. So just keeping things going is probably the best approach anyway, and just kind of not ever hitting a point or an age where we're discrediting intervention, especially kind of goes back to that motivation question, but especially, you know, remembering that it is a long time progress. It is a slow progress over time. And just that there's not a ceiling in most conditions. I mean, there are always conditions, but there are still, we don't typically treat things with a ceiling because variables change. So just keeping it going is the best way to impact that over time and keep skill development happening for despite whatever age the child is or adult.
I love that. Thank you, Tally.
Well, just Nerissa, just one other
Yeah.
comment that I'll make is that I think this generation of our children growing up is actually going to do better than the generations that were before. So if you do end up in the high P2 community, as we're finding adults who are in their 30s, 40s, 50s, I think because we've been, in a good way, folks like say, so aggressive about early aggressive intervention, treatment of epilepsy, all of the things that get in early while the brain is still developing and maximally responsive. I do think we're going to have better prognosis for the next generation or the generation growing up now.
Wonderful. Great point. Dr. Chung, we have another question for you also for gene editing, asking for an update. And how do I sign my child up for any clinical trials? And are there any other interventions currently in study for our kids?
Yeah, great questions. I'll refer you back. I know everyone wasn't able to make it on Friday because we have people work and people have other responsibilities, but we do have a whole session actually on genetically based therapies. I gave a little talk, Tim, you gave a talk, and then we had a nice question and answer period. So when that's posted, I will refer you back to that because you can hear a lot more than I can give you with the short version now. So one thing is that when there are clinical trials, so this is not just for genetic therapies, but for any intervention, we're pretty good about registering them on a website called clinicaltrials.gov, just all one word, clinical trials, and then .gov. So that's a good place to be able to go and see any new updates. Number two, and Nerissa is really great about this. I am absolutely positively sure that if Nerissa hears any whiff of even a planning of a clinical trial, it'll be on the Facebook page immediately. So as long as you're on the Facebook page and getting a feed from that, I'm sure that's you'll hear from that too. The third is that I'll say with Simon's Searchlight, even if it's not Simon's Searchlight that's running the clinical trial, but we're committed to notifying the community as other things are coming up. So you'll get a sort of e-blast out in terms of opportunities. We're not saying you have to do the study, but we're just trying to make sure that everyone's getting all information and here's all choices. I don't know of anything in the works right now. So I've got my ear to the ground in terms of listening for anything. Again, I think Nerissa would have told you if she'd heard anything, but I don't know of anything right now that's planned, either in terms of a pill, in terms of a gene therapy, gene addition, ASO, any of those fancy big words you want to use. I don't know of anything for HIVE-P2 yet. I will say, though, that one of the things that you all as a community can do, because I get asked by people that are thinking they've got, I think of it as they've got hammers and we've got nails. So in other words, they've got tools to be able to think about treatment. We're the nail in terms of HIVE-P2. And they ask me all the time, well, what conditions would be amenable? If I've got this hammer, show me where the nails are as opposed to the hooks or the screws, like what would work for my hammer? One of the things they indubitably ask me right at the beginning is how many people are in the HIVE-P2 community? How many folks can you say are out there in the United States and Europe and Australia and Japan, but particular places where they would think about running clinical trials? So one of the most important things we can do right now is getting our community registered. And it's not just on the Facebook page. They want to be able to see that, yes, someone's reviewed, they really are a member of the club. We know where you are. We know about how old you are. We know about what functional status. There's some sort of minimal information. It's not too much, but they really do want to see that amount of information to make sure that there's basically a group to work with. And so Nerissa, I want to give a lot of credit for, has been a great family group leader in terms of just she works tirelessly for you guys. Not only that, but she really has rallied the troops so that as she raises awareness, she makes sure all sorts of people who are working on this know about HiveP2. She like shouts it from the mountaintops. And so this has really raised awareness and raised priority for the community when there are some companies or researchers, they could choose from hundreds of conditions, literally, but HiveP2 is right up there. But we really need you to do your part within that. So in addition to Narissa shouting from the rooftops, in addition to, all the things we do to try and promote HiveP2, rally your friends on Facebook, and, we'll make it easy peasy lemon squeezy to register. And then just another plug, unabashedly, the in-person meeting next year. So this is August 4 through 7, 2022, as a reminder, is going to be in person in Baltimore, Maryland. And it's going to be a great chance just to be able to get together and hopefully hug each other by that point, but also to be able to participate in some of the research that we've talked about. So being able to register for those of you who might want to give blood samples, will make it easy to give blood at that time. Dr. Sid, I hope, is going to be there. A bunch of other researchers will be there. So a great chance to meet us in person and ask us those questions in the hall that maybe you don't want to ask in front of everyone else, but we'll all be there, hopefully having a great time.
Okay, wonderful. We got our genome testing done 6 years ago. Should we get another test or analysis done?
So maybe I'll start by answering that, and Dr. Sid can chime in if he has other ideas. So your genome doesn't change. So, and fundamentally that genetic information shouldn't change. If you have what I call a definitive diagnosis, and if you look at your genetic test report, if it says HiveP2 and the words either pathogenic or likely pathogenic appear on your report, then to me, that's a definitive diagnosis, and you found your right home. You found the right group, you're in the right club, and it's unlikely that you're going to get a different interpretation. And you definitely shouldn't have to repeat that test and pay for it all over again. If you got something that said variants of uncertain significance, that is a chance to be able to, number one, go back to the doctor who ordered that test and ask them to ask the laboratory for a reinterpretation. They can then be able to look at that information again. You shouldn't have to pay any more for the testing. You shouldn't have to give a new blood sample or anything. They can simply look back again and see whether or not, based on all of the collective knowledge that we have, whether they would interpret your genetic information differently. That is definitely worth doing if you're in that category.
Great. One last question. I have noticed that my child does have staring spells that don't necessarily last long, but trying to get him out of them is near impossible. Would seizures be a cause for concern, and should this be brought up with their neurologist?
Yeah, that's a great question. I think if it's hard to, so I guess the first thing is to try to do some of the things that I talked about earlier to see if you can elicit responsiveness during the spell. So calling the child's name, tapping on their, gently shaking their hand, and then some of these more almost obnoxious maneuvers, blowing in their face, tickling their nose to see, do they kind of startle or change their state in response to that stimuli. Often sometimes it's really hard to do so, or these events are brief and there's just a question mark. I think I probably would bring it to the neurologist's attention. And often if you can videotape it also during videotaping the spell itself is helpful, because the neurologist can take a look and see what the child is doing during and after the spell. That's the useful information. Sometimes the neurologist may start with a regular EEG, something that's about 30 minutes long, capturing awake and sleep. And if that's completely normal, they may or may not suggest further testing, such as a longer EEG. But if the EEG is abnormal, then one potential next step is a longer study to try to capture the event during the spell. So sometimes we do 24, 48, 72-hour EEGs. This is all predicated on the fact that the spells are happening with enough frequency that you could capture it on EEG. So if it's happening once a week or once a month, I think even getting a prolonged EEGs, it's not going to answer your question. But if they are happening with enough frequency such that, anywhere from a routine to, 2 to 3 day EEG could capture it, then I think that might be a reasonable next step.
Wonderful. Well, this brings us to the end of our session, and I wanted to thank everyone for joining the panel Q&A. We hope that you've learned valuable information from all of our amazing speakers. And thank you so much to our speakers for sharing their presentation and participating in the Q&A. Thank you so much, everybody.